So at the BC CDC, we're interested in seeing if we can use molecular surveillance. So that's the use of molecular tools such as DNA sequencing and combining that with epidemiology as a way of enhancing understanding of the HCV disease burden and increasing surveillance. So this is specifically improving incidence estimates, so looking at the new number of infections that are occurring versus the overall prevalence and overall burden of disease. Also, we can use this to track transmission patterns of HCV and overall use these tools to help inform the implementation of treatment versus prevention, or maybe treatment as prevention and harm reduction services. So at the BC CDC, we do about over 95% of testing for HCV across the province. And with that, we are able to use that to track a number of recent infections that occur every year by tracking the anti-HCV results over time. So through this, we can identify seroconverters, and those are individuals who test negative at one point in time and then later on test positive. And so we can estimate when they're infected, obviously sometime between point A and point B, and identify a certain number of recent infections in this manner for improving incidence estimates. But unfortunately, only about 15% of new diagnoses have a previous negative test available. So the remaining people, we don't know when they were infected. So our research goals are to try to develop some molecular tools and test these tools to see if we can use them to help enhance provincial surveillance of HCV. So we've looked at using phylogenetics as a way of identifying recent transmission clusters, using timing methods such as molecular clocks to try to estimate when these clusters originate, and also using deep sequencing strategies to look at intra-host variation of HCV to see if that correlates with someone being in the acute phase versus a chronic phase of infection. So this is just a model phylogenetic tree, and some things that are important to know for HCV is obviously a rapidly mutating virus, so that means there's a huge amount of variation of HCV within the population. So when you identify two individuals that have a closely related sequence, that suggests a shared transmission event, whether that was recent or could have been further back in history. But what phylogenetics allows you to do is to put together all your sequences and try to figure out how they're related to each other. And new tools are allowing you to scale phylogenetic trees to time to try to infer when these different relationships kind of came together in history. So some important points about that I'll be mentioning. One is the patristic distance. So that is just referring to the distance between two sequences in a phylogenetic tree. And the smaller that distance is, the more closely related two sequences are. Also important is looking at sampling time. So if you have sequences taken from different points in time, that helps you scale your phylogenetic tree to time. And that allows you to estimate divergence times, which is when two sequences of interest diverge from each other. So that could be a transmission timing, or it could just refer to a common ancestor in history that led to the two sequences that you're looking at. So the methods that we used were to use Sanger sequencing, looking at the HCV NS5B, as well as a region connecting the core E1 and HVR1. And these sequences were aligned, build phylogenetic trees. In this case, this was not a timed tree. This is a larger method, allows you to look at a lot of sequences. And within our tree, we have several individuals that have more than one sequence available, and these sequences are collected less than a year apart. And what we do is measure the patristic distance between these two sequences from one individual, and then use that distance to set a cutoff to the entire tree. And then any different individuals that have a distance that's below that distance, as if it came from two sequences from one patient, we consider those to be the most recent transmission clusters, because those sequences are going to be so similar to each other. So our test sample set was to look at individuals that tested anti-HCV positive in 2011 in British Columbia. So all the sequences were from 2011. And we were able to sequence 25 individuals that had 2 or 3 samples collected less than a year apart. So that was used to calibrate the cutoffs. So we had 646 samples that we were able to sequence, and there was a different distribution of the different regions in those samples. And we had some information on age, gender, HIV status, seroconverter versus, whether they're seroconverters or first-time positive, and limited geographical information. So we built a phylogenetic tree with all those sequences and plotted the distances between all the sequences in those trees. So in blue is the distances between sequences from different patients. In pink is distance between two sequences from the same patient. And then we set cutoffs, so that in pink is from the same patient. So we set cutoffs just above that distribution. And then that captures just a small number of clusters out of our entire sequence set that likely represent the most recent transmission events from that phylogenetic tree. And so that was done in all 3 regions. This is just a figure just showing the different clusters that we identified in the different regions, and we also looked at 2 close cutoffs in each region. We also looked at only had limited information, but the few factors that we knew, we looked at whether any of them were associated with those in clusters compared to those not in clusters. And so those in clusters were more likely to be younger in age, which is not surprising for more recent infections. They're also more likely to be seroconverters, and more specifically, more likely to be recent seroconverters, so more likely to have a known infection that was for sure less than a year. And so this just kind of supports our prediction that these clusters are recent transmission events. More recently, I'm looking at using a program called BEAST to timescale phylogenetic trees. The limitation is that you can look at only about 300 sequences at a time. So it's kind of something that you can apply after you do your first method of looking at all these clusters and try to time when these transmission clusters arose in history. So this is just one tree that I've generated, and it's shown so far that the clusters we identified using the previous method seem to have diverged about 1 to 3 years ago, so more recently in time. And I just wanted to briefly touch on something else that we're looking at, which is using deep sequencing to try to time infection events. So what we've done is sequenced a small amplicon of the HCV NS5B region, about 400 base pairs, and then looked at the intrahost diversity of HCV NS5B in different individuals, and diversity was measured using 2 different parameters, Shannon's entropy and single nucleotide variant analysis. So we looked at the diversity in 94 known seroconverters with acute or chronic infection, and we also did a narrow data set, which were individuals that had more well-defined timing of infection, so they only had 6-month window between the last negative and first positive, so we're more certain of when they were infected. In either case, there was a significant difference between diversity in acute and chronic infections in both of the measures of diversity. And so the next stage is to get more samples, a larger data set, to see if we can come up with some cutoffs that might be applied to individuals at the time of diagnosis, which would give us an indication if they're more likely to be acutely infected at that time or chronically infected. So the overall goal, or I guess the big goal of this research, would be to be able to systematically apply tools such as these to individuals at the time of diagnosis to try to identify recent transmission clusters, to maybe estimate the timing of those clusters, and to distinguish incident infections from prevalent infections. And this would obviously just be important for helping to support the implementation and design of prevention and treatment programs, and then also help evaluate how effective these programs are if we can continually do this over time. So that's it. Thank you to Mel Crouchen, my supervisor, and also Vince Montoya did a lot of this work as well.
What's your geographical limitations?
What information do you mean?
Yes.
We have, it's pretty broad. We don't have postal code. So a health authority, I guess, local health authority, yeah.
So I'm just out of curiosity, would you be able to detect universal precaution infections? Like if there was testing done in the north, for instance, or vaccinations in the north, would there be trends within those regions of
I think theoretically you could do that. Like we have things down to, like we have the downtown east side as one of our geographical locations. So yeah, I think in some cases you could do something like that if you had enough sequences and enough clusters to make that valid.
Oh.
I'm not sure.
Thanks, Tuco.
Great presentation. I think the application of this is really important for surveillance activities. In Scotland, we rely on just doing testing of antibody and PCR to try and understand and gauge incidence out of that. So if we had another tool to do that, that would be really helpful. I just wonder, though, I'm assuming I may have missed this was on blood samples.
Yeah, serum samples.
And a lot of the surveillance that's done amongst P-word populations. It's quite tricky to employ taking blood samples
Right, 'cause
from
we do
everyone.
the blood spot.
Yeah, and I was just wondering whether it could
Yeah.
move in that direction.
I think there's a lot of sensitivity that you can get with sequencing. With deep sequencing, you could potentially get a sequence. You can do shotgun sequencing and get all the different fragments in there. It's pretty sensitive, so I think the potential is there, but the cost is probably pretty high and maybe technically difficult.
Okay, great.